Well, thank you for asking me to give this talk. I really like coming to St. Gallen, and it's very nice to be back. So there's the title. Here's the dogma. Many new therapies available to women with recurrent breast cancer make earlier detection and treatment essential. And it seems fairly obvious that, doesn't it, really? Well, there are several obvious reasons why you might want to do breast cancer follow-up, the most important being to improve the outcome by earlier detection of recurrence, perhaps to improve quality of life by earlier detection of recurrence, to detect late treatment-related side effects, more and more important as survivorship goes up, and then from a research point of view to collect long-term follow-up data. And there's the more specialized argument for detecting new primaries in high-risk patients. So it seems like a good idea, good reasons for doing it. Problem is that the evidence suggests that it doesn't really make a difference. So first of all, if we look at intensive follow-up versus standard, these are 3 randomized trials which were published by the Cochrane Library. And they looked at intensive imaging and biochemistry versus standard clinical and mammography. The design was a bit different, but they were all asking the same question. Well over 3,000 women, no difference in survival or disease-free survival, no difference in 5-year mortality relating to any parameter that might matter, and in one of the studies, no difference in the quality of life. This is a slide taken from the 10-year update of one of these trials, and it absolutely speaks for itself. Here is a more recent trial which was carried out in Finland, and this was a 4-arm trial, 3 months follow-up, 3 monthly follow-up with routine tests. And you see the routine tests were fairly intensive, included tumor marker CA15-3, chest X-ray, liver, ultrasound, bone scan, etc. The second arm was 3 monthly without these routine tests. The third arm was 6 monthly with the tests. The fourth arm was 6 monthly without the tests. So very intensive at the top, least intensive at the bottom. Again, no significant difference in disease-free survival or overall survival. The cost of doing it more intensively was doubled, and the cost per recurrence was about 5-fold higher. So why do we do it? Well, you say to yourself, well, tests reassure patients. But actually, there's no difference in quality of life where that's been looked at. There's up to 50% false positive rates from more intensive tests. There's data from Dan Hayes that was published some years ago. There's data that suggests that more tests produce more anxiety, and you'll all know that in your clinics, patients waiting to get the results of the tests, etc. And there is some evidence from one of the trials that I've reported to you that patients prefer on-demand follow-up without using extra resources. So why do we do it then? Because we do it and patients want it. And patients want it because it's our fault. Because we tell them it's a good idea. Well-meaning charities tell them it's a good idea. The media all the time are telling them that it's a good idea. Now, there is some evidence that if you explain properly, maybe that makes a difference. None of the data that I'm showing you, as you'll have spotted already, is of the quality and depth and power of the large randomized adjuvant trials that we're all used to. But nevertheless, here's a small study reported by Charles LaPrincey some years ago now, and he basically took a small group of patients and asked them how important they thought that follow-up was, and this is what they said. And then he explained the kind of things that I've been explaining now and asked them again, and it's no surprise that the desire to have these tests went down. So maybe there's a bit, it's not maybe, for certain, there's a big educational issue here. None of the trials that I've talked about include PET CT scanning, which is the latest kind of kid on the block. But there are some recent data on these. There's a review of 28 studies of varying size and quality And they show, as you would imagine, that PET-CT scanning improves diagnostic accuracy. I don't think that's a big surprise, but there's none of these trials up until now that show there's any improvement in patient outcomes. Okay, you may pick up the disease a little earlier, doesn't seem to matter. There are 2 economic evaluation studies, and you see there's an enormous cost per QALY. I can't actually see why you can get a QALY at all if there's no improved patient outcome. But anyway, if there is a QALY, it costs you an awful lot of money indeed. And the £42,000 at the bottom, that goes down every day, as you will be aware. So, current guidelines. ASCO guidelines, ESMO guidelines, St. Gallen guidelines. They all say the same thing. Careful history taking, physical examination, regular mammography are recommended for the appropriate detection of breast cancer recurrence. Examination 3 to 6 monthly for the first 3 years, and so on and so on. The use of more elaborate tests, and I've listed them all, is not recommended for routine breast cancer follow-up. And that's a strong statement, and it's pretty universal. Now, I would challenge even the first 2 statements as being non-evidence-based, but it's still a kind of dogma that, well, we've got to do something, and I want just to spend the last few minutes going into that in a little more detail. So, does it matter who does follow up? Well, here's a trial comparing the specialist follow-up with the primary care family physician. And guess what? No significant differences in recurrence or death or quality of life. Here is a smaller trial, excuse me, comparing specialist follow-up with nurse-led follow-up. Longer follow-up time in this trial, and again, no significant differences in recurrence, in death, or in quality of life. Here's an interesting paper that was published recently from Boston, from the Dana-Farber, and breast cancer survivors were asked to answer a questionnaire. They'd all done at least 2 years since their diagnosis, and the follow-up seemed to be a bit variable, sometimes by medical oncologists, sometimes by surgeons, sometimes by clinical oncologists, sometimes by primary care physicians, and sometimes by nurse practitioners. So, what did the patients think? Well, the patients preferred medical oncologists. I mean, that's pretty obvious, isn't it? But they were quite comfortable also with primary care physicians and indeed with nurse practitioners. They didn't like what was described as a virtual visit, which means a telephone consultation. But they thought, and I think, that the nurse practitioner-led follow-up offered a promising route for improving quality and satisfaction for survivor care. We've been doing this at the Royal Marsden for a couple of years now. We call it open access follow-up. It's not our idea. It was developed by a hospital quite near us, led by someone called Jane Mayer. And there are some home truths behind what we've decided to do. Most occurrences are identified by patients themselves. It's extremely unusual for them to be picked up in the routine appointment. More women are surviving breast cancer than ever before, so our follow-up clinic's getting bigger and bigger. I presume yours are, ours certainly were. Patients are often seen by the least experienced junior doctor in the follow-up clinic because they're seen as simple and straightforward. Routine follow-up appointments are often the cause of great anxiety, as you will all know when you work in these clinics. Patients tell me they can't sleep at night and so on, thinking about the follow-up that's coming. And there is some evidence that patients may delay reporting symptoms if an appointment is not too far away in perhaps 1 or 2 months, instead of coming up with the symptoms quicker. So it might even be detrimental. So what we did was we stopped completely routine follow-up appointments in our specialist breast cancer clinics. And at the completion of primary treatment, the patient was referred to a clinical nurse specialist. And at that consultation, the nurse specialist reviewed the diagnosis, the treatment, possible late sequelae, possible symptoms of signs of recurrence, and the patients were given an information pack. And it's interesting, we went back how many patients we weren't actually formally doing that ourselves. We thought we were, but it wasn't formal and standardized the way it is now. Annual mammograms are rescheduled, and patients are advised to phone the specialist nurse if they have any concerns. The specialist nurse then does a kind of triage. If she can answer the question, if she can sort things out, she does so. Otherwise, the patient comes back to the clinic. So here's what's happening so far. In the first 2 years, we've referred 2,200 follow-up patients to these open access follow-up clinics. I mean, that just in itself shows the volume of work that we're talking about. The nurses are averaging 55 phone calls a month. It's about 3 per working day. And the main queries are about breast symptoms, followed by menopausal symptoms. There's a lot of queries about reconstructions. There's the general issues of psychosocial support. Only 10 to 15% of calls need a clinic visit. So and it's mainly about breast lumps, which obviously you can't just reassure over the phone. So there is an absolutely massive reduction in the number of patients coming to our follow-up clinics. And the ones who are coming because they've got a relevant problem. Now, the only thing that slightly worries me is the 55 phone calls a day, because the total number of patients in follow-up is increasing all the time, and that number may creep up. So I think this is a good idea, and our colleagues do. And interestingly, the patients that we ask seem, by and large, to be very happy with this. Very few refuse to be referred. So in the final couple of minutes, what's new? Well, there are 2 things that I think we need to take into account. The first is that we've got more sensitive tests under investigation. Peripheral blood tumor cells, plasma tumor-derived DNA. I've put a question mark because these tests are under investigation. There are technological issues, and there's, of course, the very important issue of, are they actually helping? And the other issue is the development of targeted therapies. Just one slide on tumor-derived DNA. These are really interesting data, very small numbers, in colorectal cancer, and you may well have seen these before, but it shows in this small group of patients that with tumor-derived circulating DNA, if you don't have it, you do really well, but if you do, you do badly. And these patients in this group obviously are worth more intensive follow-up. And that test did a lot better than standard tumor marker CEA. And then the other slide I want to show you, you've without doubt all seen many times. This is perhaps one of the most important slides in the breast cancer over the last 15 years. And these were the original data in metastatic breast cancer showing the addition of trastuzumab to chemotherapy, published, it seems such a long time ago, published 12 years ago now. And it showed a significant survival benefit for metastatic disease. Now, the important thing about this, one of the many important things about this trial is that 72%, the great majority, of patients who had chemotherapy alone were subsequently switched to trastuzumab when they relapsed. And yet there was still a significant survival difference. These 2 curves reflect the fact that the majority of patients in both arms had trastuzumab. So there's a clear message here that the earlier use of targeted therapy, the better the patient does. And as you're all aware, we've got more drugs coming along. There's pertuzumab, there's lapatinib, there's perhaps everolimus. We're in this very exciting era. So the question is HighTech intensive follow-up going to be of benefit in the era of targeted therapy? And the danger is we just start doing this without measuring if it works or not. And I think we need this kind of trial. So we select women at high risk, and they're randomized to receive whatever it's going to be, DNA or circulating tumor cells, probably not CA15-3. If these are raised in those circumstances, but not otherwise, PET-CT scan to confirm, and then you go straight on to treatment, versus conventional follow-up and treatment when it's conventionally found. What I really like about this trial is I couldn't predict the answer. I think it's a very, very important trial. It can't quite be done yet because we've got to get the technology here right first. But as soon as we do, that's where we're going. So, in conclusion, current evidence suggests that there is no gain for intensive follow-up beyond standard guidelines. Better methods of follow-up need investigating, and I'm personally a big fan of nurse-led open access follow-up clinics, having been involved in it for a couple of years. There are several novel techniques for the earlier detection of residual recurrent disease. They're under investigation. Their potential clinical benefits unproven, and they require assessment before we just willy-nilly introduce them in a new generation of randomized trials. I realize I didn't show any conflict of interest, but I think it's pretty obvious from my talk that I don't have any. So thank you for listening.
Thank you. Thank you. Thank you, Ian.